Ladies and gentlemen, colleagues, we might get started. Thank you very much for making the time to come here for this session this afternoon. It's been a long and great day so far, and your champions to have stayed till 4 o'clock for a session from 4 to 6. So thank you for that up front. I'd like to start with an acknowledgement of the traditional owners of the land on which we gather, the Wurundjeri people of the Kulin Nation, and of their elders past and present. It's my pleasure to welcome you to this session, this World Leaders Dialogue on exploring systems approaches to chronic disease prevention. Let me instantaneously say that I'm not one of the World Leaders Dialogue. I'm here to guide those who are. I'm going to talk in a few minutes and give you a brief introduction to the systems thinking and the way that we've started to think about things in the Australian Prevention Partnership Centre, of which I'm the director. I will then introduce 3 case studies, essentially focusing on national, state and local attempts to think using system thinkings about how we use these sort of approach. I'll then ask our Professor Diane Finegood to talk more broadly about systems, frameworks and tools for about 15 minutes. And then I'm going to hand the baton as facilitator to Diane, who will then facilitate some dialogue with the panel and take questions from you about this and questions and comments. Please feel free to contribute as we go through this. Let me then, So, the title of this session we want to think about is Exploring Systems Approaches to Chronic Disease Prevention. As I've mentioned, of my several hats today, I'm wearing the one as the Director of the Australian Prevention Centre. The Australian Prevention Partnership Centre is one of 3 NHMR3 funded partnership centres. The others are in cognitive decline and sustainable healthcare. Our interests are looking at more broadly about the notion of prevention and prevention systems beyond focusing on individual areas, individual content node areas. We acknowledge that there are fantastic efforts, fantastic work going on in Australia, and there really is. We should be very proud of what's happening in Australia in the prevention space. But we believe that conceptually we have to think differently and move forward in the way that we think about prevention more generally. As I say, the partnership centres, they are jointly funded by the NHMRC and our partner organisations who you can see there. And we sit hosted by the Sachs Institute, but there are more than 20 institutions involved with the Prevention Centre around Australia, more than 40 plus investigators and different groups. And we have spread our tentacles as far as people will let us spread them to draw on that incredible expertise and experience there is around Australia. Today we're going to talk about why we think this systems approach is important and how these systems approaches can be applied in practice. There are other people around who are doing really good work in the space. Hopefully some of them have joined us today and will contribute their thoughts as well as ours to this area. We'll talk about the frameworks, the methods or tools that are described in this and what the benefits and challenges of taking this approach are. Very briefly, you all know the problems, the seriousness of chronic disease and the complexity that trying to do something about chronic disease involves. We all recognise that it involves multiple agents, multiple interacting with each other. That simplistic notion that it's just about individual choices is clearly something which is a very, very limited framework, and one that while it has served us well in some aspects, if we're ever to get on top of this epidemic, we have to think broader than that. We're convinced, and I hope you're convinced, that there is an enormous gain, benefits to be had from preventing chronic disease. We can talk about it in terms of disability and mortality. We can talk about it in terms of the costs and consequences for our population. We believe that there are lots and lots of things that we can do, and lots of things that we should try on a scale large enough to be able to show that they either do or don't work if we're going to move ahead in this space. As I've already sort of flagged to you, when we talk about this, we're talking about chronic disease and its determinants and the way we think about it as being multi-layered, as being essentially involving a whole range of different aspects that we need to consider. When we think traditionally about systems, about problems, we tend, partly because a lot of us come from health backgrounds where we tend to think linear and think rationally, we tend to think about breaking things down into pieces, breaking them down into little parts, and then trying to deal with those little parts. And we forget that those parts all form part of a larger entity, and it's the larger entity that we're concerned with. And so people have started to think about what this means, and I'm sure you've all seen maps like this, system maps, where people have started to try and pull together and flag all the different elements that go into thinking about, well, if we want to achieve this, what are the things which are going to impact? How are they going to impact? And when we start to think about that, we sometimes come up with some very interesting different thoughts about and different ways of doing things. So systems approaches, they're a perspective or a way of seeing the world. We try and see it in terms of all of those different components. We're trying to see it in its entirety, and to see it as a set of interconnected elements and relationships that involve complex feedback arrangements, as well as the sort of traditional causal pathways. We try to recognise and better understand and harness that complexity to intervene in ways that are more effective, equitable and sustainable. And I think, and when I'm asked about this at a personal level, why are you interested in this? Isn't this something that that is just what public health people do? And the answer is, actually, yes, it is. This is what I think I've always done, but I've never actually had a framework, a way of thinking about it that I could convert into a way that I could systematically apply. And for me, the exciting difference of thinking about this way is not because it's got new ideas that about it, but it gives me a way that I can, when I come to a problem, I can think systematically and apply it. And coming with that, there's a set of tools, methods and frameworks that we're just starting to get a handle on and adopt and apply in relation to that. And hopefully you'll get a better sense of that at the end of today's session. Just briefly, because we have many guests and welcome to Australia, because the case examples I'm going to use here are largely Australian-based, although they all could all be applied in many other settings. I just briefly remind our international audience that we have 3 levels of government in Australia: a national government that's supposed to set national health policy. It subsidises most of the health services provided by the state and territory governments and the private sector. It leads, as the national government, it's supposed to set national health policy. It sets a lot of legislative frameworks for regulation, for example, of drugs and foods and things like that. The state and territory governments deliver health services, including most of the acute and psychiatric services. They provide community and public health services, and they're the regulatory and monitoring arm of government. Also important from a prevention point of view is that they're the level of government which is very heavy in planning, so planning of population growth in city growth and things like that. And then we have local government levels, again an area that we tend to sort of forget a bit, but they provide important environmental controls, for example garbage and clean water and health inspectors. And in many places, and it's interesting, one of the things that we've been doing as part of the TAPS is looking at the variation around Australia in terms of how people use these different entities, and this is one of the areas where we're finding some really fascinating differences in terms of what happens between states. So quickly, let's move forward then. We're going to have 3 Australian case studies. We have one on national health and equitable eating food policy, which Sharon will present, and I'll introduce her in a minute. Then one on whole-of-government approaches using the healthy weight approach with the ACT government, which Paul Kelly will present. And then some work that we've been doing around understanding prevention systems in a local community level, recognising the fact that a lot of what goes on in the prevention space actually occurs outside of the formal structures of the health system, and Therese Reilly will talk about that. So that's my brief introduction. It's now my pleasure to start to introduce the case studies. I really don't need to introduce Sharon. She's had any of you who have been to the plenary session this morning will have heard Sharon's fantastic opening this morning. She's done the session just before this, and she's still managed to hang in there for this last session. Sharon is the Director and Professor of Health Equity of the RegNet School of Regulation and Global Governance at ANU. She's also the Director of the Menzies Centre for Health Policy at the Australian National University and co-director of the NHMRC Centre of Research and Excellence on Health Equity. Sharon.
Thank you. So I want to speak about the work that we've been doing as part of the Prevention Centre and the food project that we've been running out of RegNet. Really, I should really thank my colleague, Dr. Mel Pesgood, who's really been leading a lot of the work from RegNet. And what we're trying to do is kind of shift the way of thinking about the drivers and the policy responses to healthy eating and the inequities in healthy eating. Because often the way we do tackle that is we think about the factors within the food system. So yes, it's very important that we think about the food that's produced, the way it's processed, the way it's the retail environment. We think about the fast food outlets, and then of course what comes onto the plate and the different social and cultural practices around cooking and eating. And all of that's very important, and if we got policy that moved up that food system, I would be very, very happy. But we would also want to think about, especially when you start to think about inequities in healthy eating, we really have to think about the social system as well, you know, being able to have enough money to eat in a healthy way, being able to access the retail environments, so whether that's around affordable, accessible public transport, for example. So thinking about that wider social system in which people make their dietary choices. And then, of course, thinking about the environmental system, there's this bi-directional relationship between the natural environment and the pressures that it puts onto the food system, you know, in terms of the sort of environmental degradation that we're currently experiencing and how that's affecting the sorts of foods that are produced, the prices of foods. People will remember what happened to the prices of bananas in Australia, for example, a number of years ago. But of course, that the food system is also one of the biggest contributors to environmental destruction, and we can think about the sorts of policies in a way that is both good for health, nutrition and health, and is also good for the environment. So there's real possibilities, I think, for thinking about coherence across all of these systems, and that's certainly what within TAPS that we're very interested in seeing, how coherence can take place in the system in order, in this project's instance, in order to produce better nutrition, better diet-related health, and in a more equitable way. So what we've not done is eat what do poor people eat. What we've started to ask in the HE2 project is, what is it about the food system and the local environment that encourages or doesn't, but encourages bad diets? And then also thinking about the wider social determinants of inequities in healthy eating, so issues around, as I say, around those social systems and social policy questions as well. So what were we trying to do within this particular project within TAPS? I've listed them there, and really trying to think about, really in the way that Andrew was saying, in terms of, I think I've always been working in a systems way, but I've never called it that or never quite had that framework in my head. But so we've been trying to make that quite explicit as understanding how all of these different drivers interconnect together, connect in messy, messy, messy ways. Using that sort of approach, thinking about and assessing policies for their ability to produce health equity, and then the big question of what are the barriers and therefore opportunities to get this broad approach across governments and intersectoral action to pursue fairer and more nutritious diets. So in our first project, this is about building up this causal loop diagram, and I'll show you this incredibly messy thing in a second. This is a sanitized version of it, the building blocks towards it. And this was work that was led by a colleague, Ellie Malbon, who's a systems modeler. She's not a health or a nutrition person at all. She's a systems modeler, helping us to build up in a using a collaborative group building process to construct that. Now, again, I really don't expect you to be able to read that, but what that's demonstrating is the social policy issues, the education policy issues, the transport policy issues, the food system policy issues, and how they're all interconnected together. So if you do something in the food system, you can see how it's connected through to what happens in terms of a social policy issue and vice versa. And how by finding, and we've not got to this stage yet, but by finding the key leverage points in that system, the very effective leverage points, we can produce better and more equitable nutrition. The second part is around the HE2. So HE2 is the healthy and equitable eating framework. And we'd like to think that what we're doing is, many of you who would work in nutrition or in public health nutrition would be familiar with the Nourishing framework that came out from the World Cancer Research Fund. So really this incredible compilation of policies and programs from all over the world across a number of different policy domains within the food system. And then building on that, the work that's been happening through the Informus network led by Boyd Swinburne, again thinking about monitoring the different policies that are happening at different levels within the food system and the food environment. So we are being completely arrogant, thinking that we're going to be just like these two big global frameworks and start to think about an equivalent, but one that brings in these other policy domains, and we're starting to build that up. What are the the high-level actions that we think can and that are being taken internationally, but particularly in Australia at the moment, and then starting to populate that framework with those policies that exist around Australia and then around the world, hopefully. And then the third is working with colleagues, and we've been working very closely with Paul, and you'll obviously hear much more about what's happening in the ACT, and then with colleagues in New South Wales Health, to try and understand just what some of the difficulties are and really the opportunities for moving these sorts of agendas forward, moving that paradigm of addressing healthy eating. How can you do that within a government context and then within that broader intersectoral context? And so using qualitative research, using key informant interviews with the various players across the different government departments within the ACT Healthy Weight Initiative that I know Paul's going to tell you about now, and then similarly with colleagues in New South Wales Health, where there's the HEAL strategy, trying to understand how some of those different players within education, for example, are able to take forward an agenda to do with healthy eating. We're in the process of doing all of that analysis. I don't have any actual data to share with you on that at the moment, but that's really illuminating how, if you think about that big sort of messy system, and we're saying look at the potential for policy coherence if we think in this way, What are some of just the practical challenges to making that happen when it comes to intergovernment working and then government and NGOs and others working together? So that's just to acknowledge this is a huge, big team, as is TAPS. It's gigantic, it's fantastic, and really about the different worlds, I suppose, just to acknowledge the different worlds that are coming together in trying to do the sorts of research that I've been speaking about, and you'll hear more about, of coming at it from an academic mindset, coming at it from a policy mindset, coming at it from a practitioner mindset. That's actually been, I think, one of the most important things that we've been doing within TAPS, is bringing these different views and world views to how you think about, in this instance, inequities in healthy eating. So thanks, Andrew.
We're going to move straight through the case studies, and then if you can just write down your questions, and you'll get an opportunity to do those in the session where we have. So the second case study that we'd like to present to you will be presented by Dr. Paul Kelly. Paul's the Chief Health Officer of the Australian Capital Territory and the Deputy Director General Population Health in the ACT Government. He's a public health physician, epidemiologist, and has also had a very distinguished career, continues to have one, as a researcher in public health in that regard. He's also an enthusiastic Scottish dancer, so we've asked him to do his presentation today as interpretive Scottish dance, so just please bear with us while he does this.
I might save the reeling till later. Thanks very much, Andrew, for that enthusiastic welcome, and it's a real privilege to be here. Thanks to the organising committee and also to TAPS who have organised this session. I'd like to also join the other presenters that have acknowledged the country on which we're talking today, the country of the Wurundjeri people of the Kulin Nation, and to respect their elders past and present. My role is really to bridge the national to the local by describing a part of government which is often, or a level of government which is often forgotten. You might have seen the slide earlier about mayors running the world. I think that would be a fantastic idea. But the provincial level ACT government Healthy Weight Initiative is an example of an approach to one of the wicked problems facing those of us working to develop systems approaches to non-communicable disease prevention at that middle tier of government, and that's what I'll be describing today. Before I do that, because context is so important, I will take some time to describe the ACT and particular elements that have influenced our work, before going on to the key elements of the Healthy Weight Initiative itself, the how, the what, and the why. Finally, I will offer some reflections on this wickedness of public health problems that we all talk about from the point of view of one working with them daily as a public health physician in government, and relating all of this to the themes of the session. So the ACT is a jurisdiction with some unique characteristics. Those Australians in the audience often call us weird, and we are a little. We have a single tier of government. All of the things that Andrew talked about earlier about the national, provincial level and the local. In the ACT, the provincial and the local are one government, so that gives some advantages. It's a relatively small population, and virtually all of us live in a single low-density metropolitan area. We're highly car dependent, and we eat out a lot, including the world champion barista, so it is possible to get a good coffee in other places other than Melbourne. So some would describe this as a rather obesogenic environment. On the other hand, Canberra, and despite what was said at the plenary earlier by I think 3 speakers, the OECD, a far more trusted judge of these things, designated Canberra to be the world's most livable city in 1914, it wasn't there, 2014. Anyway, it's a great place to live, and it's truly healthy, wealthy and wise. It has Australia's highest life expectancy, highest per capita income, lowest unemployment rate and highest school retention rate. There is also excellent infrastructure to promote physical activity such as cycleways and other things, and wide access to both nutritious food and world-class health facilities. All of the preconditions, therefore, for a lower obesity rate. And here is what I call the Canberra paradox. Despite all of these advantages, which should see us leading the nation in terms of healthy lifestyles, ACT faces the same burden of chronic diseases as the rest of Australia, including, and importantly for this presentation, the obesity rate, and 2/3 of adults and 1 in 4 children are either overweight or obese. So there's a problem. Hence we developed this plan. This provincial level example of a systems approach to public health action by government to address obesity, the ACT Towards Zero Growth Healthy Weight Initiative. We'll talk more about frameworks later in the session, but in policy development, I'm a fan of John Kingdon's 3 streams theory: problems, solutions, and politics. Crucial to this theory is the idea of windows of opportunity, which arise when all 3 streams come together. One such stream opened in 2010. Prompted by the rapid and alarming rise in obesity rates in the ACT, the then Health and later Chief Minister requested a whole of government obesity prevention plan and asked me to deliver it. Unfortunately, as this window opened, we did not have a coherent set of solutions. The scale and the causes of the problem remained highly contested, and there was no clear mechanism for breaking down the silos to allow the long-term coordinated action across government which would be required to address such a wicked problem. In the next few slides, I will describe how the plan was conceived and some of the challenges with conceptualising and implementing it. First, we needed to scope the problem and the potential solutions. We commissioned a review of the literature about what was likely to be effective, affordable, and crucially, feasible in the ACT. This turned out to be a rather underwhelming list. At that time, so we're talking 2010, 2011, around there was a paucity of evaluated interventional studies designed to produce widely applicable findings. Recommended actions, therefore, relied on an innovative metric which we labelled as level of promise, rather than evidence-based. We undertook a quick review of programs in other jurisdictions. We also performed a map and gap of existing policies and programs in the ACT. And we created, crucially at that time, a coalition of the willing. And then we called for suggested new initiatives from that coalition with a quasi-democratic voting process to achieve consensus. Essentially, everyone voted, and then I chose. So despite the contest and compromise, we landed in what I would consider the action-oriented part of Tom Friedman's pyramid. This was a systems approach with a population focus and proposed changes to the context in schools, in workplaces, and the wider community to assist in making the healthy choice the easier choice. Crucial governance elements included central agency coordination, continued strong technical input from my team, and a dispersed responsibility model with collaboration across sectors. How many people know this quote? This is from Ronald Reagan some years ago, and it was about the economy. If it moves, tax it. If it keeps moving, regulate it. And if it stops moving, subsidise it. That's what the government does. But actually, when you think about it, it's also what we have available to us in government to do work around these wicked problems. At this point, I don't intend to provide details about the individual programs or policy proposals. You can look that up on the website. But suffice it to say, they were all subsets of this somewhat depressing summary of the powers available to governments in the 1980s. To make matters even more difficult at the state level in Australia, due to the nature of our federal constitution, we can't tax. So we were therefore limited to leading by example through policy and practice, legislating or regulating, paying for stuff through incentives or by outsourcing to NGOs and or the private sector, and advocating, of course, for taxation at the national level. So the final step was to take a series of 19 potential programs in 6 potential clusters to a recently formed strategic board consisting of the heads of all ACT government departments. To our surprise, they directed us to implement all 19. 3.5 years on, many of these initiatives have in fact been completed, and there have been some progress on all of the actions. But there has been a tendency through this period to shy away from the regulatory approach, which was so strongly mentioned in the original plan, and to label many upstream interventions, which were not part of the original plan, as being part of the initiative. Here's one example I will give of the integrated approach. Work started through the Healthy Weight Initiative on modifying the active living environment to increase active transport, including the use of public transport. In addition, an existing school-based program, co-sponsored by the Education and Health Departments in the ACT, was expanded to promote active travel to and from school. Finally, a new program to facilitate safe travel to school was initiated to support the aforementioned programs, and this was based on the key evaluation finding that safety concerns by parents were the main barrier to their consent. This illustrates a key concept in the Healthy Weight Initiative work, that of co-production and co-benefit, and you would have heard those in multiple talks this morning. Where these have been well articulated with agreed positions amongst like-minded individuals with influence, things have really worked well. Where these conditions have not been met, programs have in general not produced the desired effect, scale or persistence. So building on work by Armstrong and others here in Melbourne, here is my take on wickedness, which needs to be understood and carefully managed when attempting to use a systematic approach to tackle public health problems. The concept of evidence is much more complicated in the real world of population health practice, and particularly when one strives to influence sectors outside of the health departments. Many types of information, personal opinion and experience, timing, the political cycle, local norms, the influence of external players, the availability of funds, all influence decision-making. We saw all of these play out in the prolonged consensus process which we needed to undertake to achieve whole-of-government buy-in to the Healthy Weight Initiative, even despite the strong authorising environment from the Chief Minister, our head of government, which we enjoyed during this period. And so I return to the session themes. How are we faring? Well, I think we can say that we have had consistent leadership within government, and the messaging to the community has also been crucial. Obesity is a problem for individuals, government expenditure, and the community in the ACT. And scaled-up interventions, which may include increased regulation, are crucial to truly address the problem. These messages have been repeated, often loudly, and by many within and outside government during this time. We've been coordinated. We still have that strong coalition of the willing, and this has helped to sustain and expand the efforts. It's been intense. The scale of interventions are impressive, particularly in children in elementary schools, and there's a talk in another session about that if you're interested. The food environment for adults has been the most challenging area, and despite strong statements in the Healthy Weight Action Plan, it hasn't progressed as quickly or to scale as we had hoped. Persistence is one of the issues that we should return to in our discussion. A strong commitment to prevention and a clear recognition that obesity remains a problem persists. However, after almost 4 years of, we're running into policy fatigue, which is one of the real challenges of working in an area which must be more like a marathon than a sprint. So is it working? There are early indications of a downward trend in overweight and obesity in our Year 6 children. Of course, the Healthy Weight Initiative is not the only thing going on here, so attribution, in my view, is actually probably impossible to prove. However, I remain optimistic that we can achieve significant improvement in this key chronic disease determinant, at least for the next generation. It's my firm belief that the systematic approach we have taken up to now has been and will remain key to achieving this worthy goal. Thank you.
Thanks, Paul. The third case study from Therese will be presented by Dr. Therese Reilly. Therese is a Senior Research Fellow with the Australian Prevention Partnership Centre. She's based here in Melbourne. Until recently, she was with the Centre of Excellence in Intervention and Prevention Science. She has a background in the sociology of technology and has brought some incredibly creative thinking to this particular project that she'll talk about today. But just as a brief personal introduction to that, one of the origins of this particular project was a sense that I had that we were not capturing the full exposure that people had to prevention in our community. It was at a time when the National Partnership Agreements on Preventive Health had started to fall over, ANFA had been dissolved, and there was a sense of despair in the public health community about what was going on in prevention. And yet, when I looked out into the real communities, I could still see an awful lot of things happening. And that led us to sort of start to think about the fact that we were not really fully appreciating what was really happening within the community. And that's part of the origins of the project that Therese will describe.
Thanks, Andrew. I've started to get a bit worried that maybe I needed to change all my slides. Just let me apologise first. I have a bit of a post-viral cough at the moment. I also have a vision impairment, so this kind of darkness is freaking me out just a little bit. And what that means is that I will tend to look down at my paper or turn around to see what's on the big screen. But rest assured, these are my slides, and I have actually written them in notes, at least some of the material. I would also like to acknowledge the fact that we're meeting today on the land of the Wurundjeri people as the first custodians of the land in which we're meeting, and pay my respects to elders past and present, and also to extend that respect to any Aboriginal and Torres Strait Islander and First Nation people who are present and with us today. So what I plan to talk about is to give you a bit of a sense of the Prevention Tracker initiative, the structure of Prevention Tracker, and some of the fundamental assumptions that Prevention Tracker is based on as the kind of first port of call. I also then want to go on and give you a bit of a sense of what it actually looks like in practice in local communities, to talk about what approach we've taken in terms of systems thinking or the application of systems science, and some of the challenges and opportunities that's presented for us. Doubtless that there are some team members in the audience, but I can't see you, I'm afraid, who are probably wondering how we could possibly fit the challenges only onto one slide. Maybe that'll be a part of the discussion. So Prevention Tracker is a national initiative, and by that we mean that it's operating in 4 communities across Australia. So it's happening in Albany in Western Australia, Broken Hill in New South Wales, Glenorchy in Tasmania, and the Gold Coast in Queensland. So we do spend a lot of time doing work at airports, which has posed its own set of challenges. The structure of Prevention Tracker is that we have a key local partner organisation in each of the local communities, and we have a memorandum of understanding with the partner organisation, which I understand is quite a traditional instrument, but provides, I guess, the mechanism for us to have those initial discussions. We also have a local advisory group, and that's an opportunity to extend the involvement of a range of other players, organisations and people from within the local community who have an opportunity to guide and adapt Prevention Tracker in the community context, and I'll talk about that in a moment. But more than just working with partner organisations and other key stakeholders in the communities, we've also drawn on an extended network of researchers from across TAPS. And TAPS itself has created a fantastic infrastructure for us to be able to draw in skills in issues of aspects of system science methods such as social network analysis, but also in the expertise of the application of systemic inquiry processes. And that's certainly been very critical for Prevention Tracker to have gotten as far as it has. As you see, we're due for completion in June next year, so we're not as far advanced as the work undertaken by Sharon and Paul. So we've certainly still got a bit of a ways to go. The broad framework for Prevention Tracker is that it aims to describe, guide and monitor system change efforts within communities. And there are many assumptions upon which Prevention Tracker is based, but there are 2 that I think are really important for the discussion that we're having this afternoon. And the first is groundbreaking as this might sound, but prevention systems already exist in local communities. So there are already people and organisations, as Andrew spoke about. There are people, organisations, networks, programs, a history of effort, of beliefs and norms and values, and all of which are working to improve the health of local communities. So the first assumption that Prevention Tracker is based on is that initially we need to describe, work with our local partners and advisory groups to describe and perhaps better understand and gain new insights into how the prevention system operates within local communities as our starting point. The assumption being in that in understanding and gaining new insights into those contexts, we'll be better able to create opportunities for effective change within that system. So that's the first assumption. The second assumption is that systemic inquiry processes will lead to systems change. And here I can paraphrase the work of Penny Foster-Fishman and Erin Watson in the US, who say that change efforts quite often focus on the surface aspects of local problems and rarely focus in on the underlying systemic conditions that bring rise to these local problems within local communities. And that's what we're aiming in Prevention Tracker. And there are two aspects of that I'll just pull apart just briefly. The first is systemic, and by systemic we mean relational and connected and holistic. So the focus of our insights in describing the nature of the prevention system and guiding change efforts is to constantly focus on the systemic aspects of what might be going on, the interconnections and the relationships between things, rather than any one component of the prevention system, the kind of work that Sharon talked about initially in the first presentation, So we need to focus in on that, kind of constantly refocus our attention and make sure we're focusing on the systemic aspects of the system. And the second is inquiry. And as researchers, this is what we're in the business of. We engage modes of scientific reasoning that direct our methodological efforts and present to us findings that unfortunately we quite often hand to others to implement, people like you, Paul. And then we step out. In Prevention Tracker, we're opening up the opportunity to engage in that inquiry process to local stakeholders and partners. So within Prevention Tracker, that inquiry in terms of guiding decisions made in terms of methodological adaptation, to interpret and reinterpret data, to work with local community stakeholders in the creation of models in the context in which they can be acted upon. And so that second assumption is that engaging in those kind of systemic inquiry processes, drawing the people who will act on the knowledge into its own creation, maintaining that systemic focus will bring about systems change. And of course, that's ultimately up to what we're hoping to achieve. That didn't move. Whoop. No, I need to go back. Sorry. Aha. So what does this mean in practice? So the first aspect of Prevention Tracker, or the first phase, is to describe the local prevention system. And we've applied a range of different methods in the communities and we're at various points in time with the work with the communities to describe aspects of the prevention system. And I've presented just a few here. So we work with the local advisory group to bring together an infographic of the nature of the community in terms of its people and its health, to map livability indicators for the environmental conditions that may affect people's choices, such as access to fresh and healthy food, or distance from liquor outlets, or the distribution of the population that doesn't have an access to a car, which in many of the regional communities is a key factor in whether or not they can access fresh and healthy food, for example. We collected data on the nature of the prevention workforce, which is the human capital of prevention, the skills, the capabilities that are at the community's disposal in terms of implementing prevention efforts, but also the organisations involved in prevention who are active. How are they connected? How do they share information, resources, joint plan and engage in joint funding? And there are many other aspects of that data collection in describing the prevention system. But of course, what we didn't want to do was create all these insights from the outside, even though our advisory group assisted us in the adaptation of those methods. And what you see in the middle here is a community map that we commissioned a graphic artist to pull together various aspects of this data into one community map, and in this case, it's of Glenorchy in Tasmania. We used this as a device to engage in data synthesis workshops with the local community. So these were members of our advisory group and then expanded out into other people and organisations within the prevention system. And that provided a unique opportunity to be able to invite people to interrogate the nature of the data, to discuss and describe why things are the way they are, to layer on new information that might be more temporally relevant into the community at that point in time. The stakeholders involved in those workshops were also invited to look for patterns in the data to help describe why things might be looking the way they are. The outcome of this process was the identification of a key local problem that would then form the basis of the next process of inquiry within Prevention Tracker. And what we found really exciting and interesting within the Prevention Tracker team is that in both cases where we've undertaken this with 2 communities so far, the local problem that was seen as critical to strengthening the local prevention system was, in one case, how to better engage a diverse set of voices and organisations in prevention, so how to make sure that there are multiple voices in any decisions, but also how to reach across traditional prevention boundaries in undertaking prevention efforts. And in another community, it was about how to strengthen and improve collaborative practices and the skills and the commitment and value of collaborative practice as one way to reach across traditional silos. So in both instances, even though these maps spent a considerable amount of time talking about aspects of risk factors, chronic disease, and how it might be distributed across the community, the communities and the range of stakeholders actually looked through those health problems to some of the systemic conditions that they thought were critical in why things continue to be the way they are in those communities. The next process, and I should say the next part of this process, is that in one of the communities we've already used that locally identified problem to undertake some group model building, and at the moment they're creating causal loop diagrams on that key local problem, and we've undertaken a number of those kind of workshops. So that's certainly the next stage, or the next phase. So what is the nature of our systems approach? It is about the application of systemic inquiry processes and methods. And here I'm just pulling out a couple of the key conceptual guides that we've used to assist us in thinking about how do we create a coherence in this work. The first is to focus on the systemic nature of what might be going on and that description, and I've spoken about that. Also about understanding the situations or problems in context and making sure that the context is the reference point that we constantly come back to with our local advisory group and community stakeholders, but also within our team, and use that as our reference point in creating new and additional insights. And we've undertaken a range of different approaches to be able to achieve that so far. We also want to create a learning environment, which is a key aspect often banged on about by the soft systems methodologists, but also others within systems thinking. We need to facilitate that learning, because if the learning is only from outsiders into communities, then change will be very slow indeed. But also, we're unlikely to be able to identify those key local factors that only local players and people can bring to the table. That social learning, sense-making together, does provide the opportunity for shared understanding, and so far that is what we've observed within Prevention Tracker. Other aspects of our systems approach is the recognition that we need to engage with multiple perspectives. The prevention system is made up of people and players and beliefs from very different vantage points across the system. And so we need to be able to engage with those multiple perspectives. We're constantly asking who now needs to be involved in the discussion as we create as we identify with the community new local problems or other issues to be addressed. Now who should be in on the conversation and a part of that process. And a part of that is the co-creation, and it's about creating for us, it's about creating knowledge or new knowledge and new insights, which is what the communities were after, and our partner organisations said that they wanted new insights. So how do we create, and making sure that we're facilitating the opportunity to create new knowledge in the context in which that knowledge can turn into action, which is a key aspect of the work that we've been doing. And I think the group processes of identifying a key local problem we could not have predicted is a good demonstration of that. So why the systems approach? I think it privileges focusing in on systemic insights rather than the particulars of any one program or risk factor, for example. And we ourselves as researchers have to constantly make sure that we're paying due attention to the system level, the structure of how things might be operating. The nice thing is that it brings together process and method. As researchers, we can be very methodologically driven, but that needs to be embedded in a process that reinforces the new insights that are gained through these methods. And I'd probably, with hindsight, add process, method and context to there. It is also about learning by doing, and I can't remember where this quote comes from, so you can shoot me down on this one. But the notion that we can act our way into new ways of thinking is something we've certainly observed within Prevention Tracker in the work that we've done, and I think that is a key notion that we constantly come back to. And it's most likely to lead to sustainable change, and I've added a question mark there because sustainability is a future event, but we're hoping that we're creating the conditions for that to happen. Some of the challenges, and this is the last slide, Andrew, is that the starting point is uncertainty and complexity, and that yikes comes from me, I think, nearly every morning, because that uncertainty means as researchers we've had to create adaptive methods and tools and be willing to change direction, and that can certainly be very confronting. Systemic inquiry at the moment, in terms of the methods and the processes, is quite specialised, and I think we need to kind of pay attention to what that means. But hopefully it also provides an opportunity to surface a lot of innovation that can happen in communities who are at the coalface of chronic disease prevention. And this is a range of people involved. And thank you.
So, 3 case studies that we could have spent an awful lot more time talking about. What we'd now like to do is, what I'm now going to do is invite Professor Diane Finegood to talk a little bit more broadly about some of the system thinking issues behind our thinking. We're really fortunate Diane is on our small group of our international advisory panel, really mentors to TAPC that have been very, very valuable to our journey. And Diane in particular has been extremely informative in that regard. Diane's a scientist, system thinker, and visionary with an exceptional track record of heading leading-edge health research organisations. She's currently a professor at the Simon Fraser University. She recently stepped down as the president and CEO of the Michael Smith Foundation for Health Research in Vancouver, British Columbia. And before that, she worked and transformed obesity research in Canada in her role as the inaugural scientific director of the Institute of Nutrition, Metabolism and Diabetes. Diane, thanks.
Thank you for your kind words, Andrew. I've enjoyed working with TAPS enormously, and thank you for this invitation. So I'm going to try to pull together a little bit and maybe make some comparisons between some of the models that you've already seen, and then we'll go into a good discussion, which we'll invite you to participate in. Before I start, I too want to acknowledge the traditional owners of the land on which we're here today, and I won't try to pronounce their name because as a Canadian I'm sure I will get it quite wrong. So frameworks and tools for systems approaches. I think we probably want to start with a few definitions. The first is system, and I tend to go to Donella Meadows for my definition of system, which is a set of things, people, cells, molecules, or whatever, interconnected in such a way that they produce their own pattern of behavior over time. So that's the kind of definition I use. Now, when it comes to finding a definition of systems approach, that's actually quite a bit more challenging. I found this one in the literature, or by using Google, of course, a line of thought, and in this case from the management field, which stresses the, and I've underlined this, interactive nature and interdependence of external and internal factors. And I think that's the part of the definition that we're going to pretty much focus on today. A colleague gave me this definition of systems thinking yesterday, a very academic approach in which they synthesized systems thinking definitions from 8 different researchers into a classic academic framing of systems thinking as a set of synergistic analytic skills used to improve the capability of identifying and understanding systems, predicting their behaviors, and devising modifications to them in order to produce desired effects. These skills work together as a system. Does anybody understand what I just said? And they built it based on the model that's in the lower right-hand corner of the slide. So anyways, just keep in mind interconnections, interdependencies, and we'll be in good shape. In fact, we'll use my favorite picture of interconnections and interdependencies, which is the obesity system map, which people who've been working in prevention, particularly in chronic disease prevention, will have seen this. It's been around for more than 10 years. And as I always say when I use this map, I put whatever label I need on it because you can't read it anyways. But the point, the reason I like to start most of my talks with this picture because it really emphasizes the interdependency aspect of a complex adaptive system. And it's the part of a complex adaptive system that makes it complex, not complicated and really contributes to the challenge that we face in trying to solve complex problems. And I do like to make that distinction between complex and complicated. So I often say complex is not the same as complicated or simple. This illustrates the characteristics that articulate the difference between simple or complicated systems and complex. And you should listen when somebody's talking about complexity. Sometimes they slip back and forth and use complicated to mean complex. Now, we don't have time to go through all these in detail and talk about them, but certainly things like heterogeneity, and when it comes to prevention, we know there's many, many different genes, for example, that contribute to a person's body weight, and as a result, clearly we're heterogeneous in applying one kind of intervention in prevention is not necessarily going to work. But also although maybe somewhat jargony, deterministic and stochastic are important, stochastic meaning random. So airplanes are complicated. Then you put a pilot in them, they start to become complex because sometimes there's random behaviors associated with individuals. But even in the area of prevention, I like to quote a study in which they looked retrospectively at people who'd gained and lost weight over a period of time and asked them what the trigger was for that weight loss or weight gain, and the list is the same. Losing a spouse, a divorce, those sorts of things. They trigger people to either lose weight or gain weight, but it depends on the individual in terms of what you get. So these are the kinds of characteristics that make up a complex system. Now, we're talking about frameworks and tools. I use these definitions. I tend to be a little bit interchangeable, but a framework is just a broad overview or outline or a skeleton that supports a particular approach to a specific objective. And it's going to be important as you think about what framework or tool you want to use, what your objective is. What is it you're trying to accomplish and communicate? And a tool, and I use tool there to describe and implement, and it can be a concept as well. Tools can be concepts. And some of the frameworks we're going to talk about can be used as tools as well as just frameworks. So these are my key messages. Frameworks and tools can be used for describing complex systems of interest, creating system maps. We've already heard something about that. System frameworks can be used to support shared understanding, and that's an important component of acting in complex systems. Systems frameworks can be used to guide action as well as support shared understanding, and they can be used for analysis and evaluation. And we'll talk a little bit about each one of these in the limited amount of time that we have. So describing the system of interest, we've already had some great presentations in this session. In public health, a very common map or model of our circumstances is a social ecological model. And I put this up here to illustrate how bad I think it is as a map or a model for complex adaptive systems, because it doesn't show you anything about interconnections. It illustrates and sort of suggests that you've got these layers of areas that affect an individual and affect the individual's outcomes or prevention, and also that are places for intervention, but it really evokes nothing about the interconnection. So I put it up there as a comparison. I also have Paul's Healthy Weight Action Plan, which we were just discussing before the session, as he points out that although it doesn't look like there's any interconnections here in the way he articulates it, when you're trying to sell the plan within the government structure, it probably is necessary to make it in these discrete areas. But again, it doesn't evoke anything about complexity. Whereas, no, I think I did press, let's see if this comes up. It's a slow one because it's such a big file. Here's the map that Therese presented in terms of the Glenorchy prevention system. And this one's quite an interesting one because it looks almost a little bit chaotic until you can zero in on a particular section. And clearly it's been a useful tool in the work that they're doing in Glenorchy. It doesn't have a lot of interconnections in it, but maybe that's not important because as you start to unpack it, you begin to see them quite clearly. But of course, Sharon's map shows lots of interconnections and interdependencies, so it evokes the notion that the system that she's working in clearly is complex. And the challenge, of course, in complex systems is when you show somebody a map like this, the common responses are retreat, despair, believing the problem's beyond hope. But what I want to try to convey to you today is that's not necessarily the case. So systems maps can be used as tools. Let's just look at a couple of examples. I come back to the obesity system map. Now, this was created by a large group of stakeholders in the UK more than 10 years ago. And although you can't understand what it says, you can actually use it if you blow it up in large frame so that you can actually see it as a tool to talk about cross-government responsibilities in an area like obesity. So in the UK, this was used for a whole of government discussion where different ministries like transportation and education and others came together to say, where were they responsible? What places on this map did they have responsibility for? So it was a tool for having a conversation about roles and responsibilities and trying to develop, again, a common understanding of the challenge. We zoomed out on the map, and so what you're seeing here is a version of the map in which each arrow its thickness is proportional to the number of underlying relationships. So it's not really quantitative, but it gives you a sense of where the stakeholders who were developing the map were focusing their attention. And it gave us a real an aha in terms of the potential bias, actually, of the stakeholders who built this particular version. And you can see it in the largest arrow is between food production and food consumption. So the people who built this map really believed there were a lot of aspects of food production that drove food consumption. But there's no return arrow. And certainly if you work in the food industry, you would argue that what people consume plays an important role in what they produce. That's not to absolve them of the responsibility they have or the role that they play in driving consumption using advertising and other things. But clearly, if people don't eat things, they're not going to be able to sell them. So this is a form of analysis, if you will, of how the individuals who were here involved in building this map articulated the important responsibilities. And it's also presented as a cautionary note that like a famous modeler said, all models are wrong, some are useful. It's probably also true that all systems maps are wrong in some fashion, but many are useful for dialogue. What about frameworks and tools for action? So Paul presented this one so that he could illustrate where in the prevention system they felt that ACT Health could act, and I think it's a good one in that sense in terms of a framework for action for government. I particularly like Donella Meadows' work on places to intervene in a complex system because she takes the frame of system and thinks about it a little bit differently, where she talks about the hardest things to change in a system are the deeply held beliefs, the paradigm under which the system operates. And going down, that drives the goals, it sets the structure of the system, it plays a role in the feedback loops and delays that exist in the system, and then all the fiddly bits down at the bottom, the constant numbers and parameters. And the key here is the recognition that at the top of the pyramid here, at the top of the places to intervene, are things that are very difficult to change, but when they change, they're very powerful and very effective for change. And if we start to think about where the evidence lies, it tends to be down at the bottom of this list. Now, we felt that this was a really interesting way to think about a system, and we wanted to analyze strategies for addressing obesity, but we quickly learned 12 levels is not a great framework for analysis. So we developed what we call the intervention level framework, which is just a little bit easier, but it sort of compacts some of what Donella Meadows had. So at the top, paradigm, deeply held beliefs, goals, structure, feedback loops and delays, and structural elements. And we found this to be actually a fairly useful framework for analysis. And so we analyzed a series that slide is missing, is it? Is it there? Nope, it is not. I somehow have left the slide out. Okay, I'm just going to go back for a second and just say that we use this to analyze strategies for looking at obesity and found that, in fact, the bulk of what you find in a strategy is down at that structural element level because that's where the evidence tends to lie. And we rarely think about the paradigm under which a system actually operates. So this is to encourage. We've also used this, well, maybe that's it. It's in a different section. For action. We have used this sorry, my apologies, but we've used this as a conversation tool in a number of workshops where we engage people in a discussion about what those deeply held beliefs are. Another framework for action is Trish Greenhall's framework for diffusion of innovation. I particularly like this framework and, because it really articulates that in a complex adaptive system, you can't let something happen. You can't make something happen, but what you have to do is to help it happen. So managerial top-down approaches don't work that well in a complex system, and just letting things happen don't help build the coherence that you need across a large system to move in a single direction. So I think this is a helpful framework. The 5 conditions of collective impact, again, is another framework that can be used for action, and it's very concrete in speaking about the common agenda, the shared measurement, the mutually reinforcing activities. Now, you're starting to see that there's some common themes that run through each of these, but the other thing to keep in mind is that depending on where you're going and what you're trying to communicate, one may be more useful than another. I like this framework for partnership development because we talk about partnerships a lot, and we don't often articulate the distinction between things like sponsorship. Some people talk about those as partnerships, which tend to be, make the organizations tend to be relatively independent, and the relationship tends to be transactional. Whereas there are also things like alliances where the relationships start to become more interdependent and collaborative versus true engaged partnerships where the organizations involved are truly interconnected and there's real co-ownership. I'm not trying to imply that there's anything wrong with any one of these, but the important value of the framework is to be able to articulate and more clearly describe the nature of the relationship you're trying to build and to think about the parameters that go with it. This is Wheatley's framework for influencing emergence, where she talks about how you go from networks to communities of practice to systems of influence. And because time is short, I don't want to spend a lot of time on it. But what she does is articulate how you can help loosely affiliated groups of people who are mostly there for self-interest to move into being a community of practice, or ultimately what we really are trying to build in public health are systems of influence. This is just language, I call it a framework for building trust, but building trust is an important component of public health and a very important component of working in complex systems, because the more trust you have when you're working in a system, the less complex it is to work in that system. So just giving it some language and understanding the difference between simple trust, authentic trust, and cordial hypocrisy can be fairly helpful for articulating how to get there. There are frameworks for adaptation instead of setting a goal. This is the Common Plan, Do, Study, Act kind of framework. And I call this my framework for solutions to complex problems. It's kind of a summary of a number of the frameworks we've just talked about, like building authentic trust, setting functional goals, distributing decision, action, and authority, moving from let it happen to help it happen, those sorts of things. And I've labeled it a framework because I really like the collection, and I think it can ultimately, maybe academically it's not quite there as a tested framework, but it's a useful set of things to think about when you're trying to address complex systems. So just quickly, I'll go through a couple of systems frameworks for analysis. This is where I got myself confused before. But this is one paper that I found that I think did a very nice job of taking 4 characteristics of complex adaptive systems and using them to rate papers around interventions for type 2 diabetes. And they actually showed, if you look at this table, which has the total number of complex adaptive systems characteristics in the column, in the left-hand column, versus the impact, and they just used a simple rating scale of 0, 0.5, and 1 for the impact of the intervention. So this was actually a synthesis article across these interventions, and they found a distinct correlation between the number of complex adaptive systems characteristics and the impact of the intervention. So I think we need to do way more of this kind of work if we're going to, whoops, I was timing myself. I'm behind, clearly. But the point being that I think this is the kind of empirical work we need way more of in order for complex adaptive systems to be an acceptable approach to addressing complex problems. Here's where I confuse myself. We use this framework to look at recommendations to address obesity across a number of strategies, and you can see that the vast majority really focus on the things that we can measure and prove that there's evidence for, and therefore they get packaged into strategies. We really need to think more about how we use things like creating feedback loops, new feedback loops, or removing feedback loops as an intervention strategy in and of itself. And this is a framework that was developed in Canada for measuring research impact. I'm just illustrating it because I think it's a helpful way to think about as we build the case for organizations like TAPC and others that are doing work to build capacity and advance knowledge in systems approaches. We need to build the case that these things then ultimately can lead to informed decision making, and the things that our government and our policymakers want us to show, which is that there's ultimately health impacts and broad economic and social impacts. So just to quickly recap, I think frameworks and tools can be useful for describing complex systems of interest. Creating system maps is in and of itself helpful, and the maps help to build support for a shared understanding. And these frameworks can also be used to guide our action, as well as analytic frames and tools. So thank you very much. Okay. So now we're going to have, we're going to have a discussion, a panel discussion. And although I've got questions in hand for, I'm going to steal this pen for a second, oh, no, I had one. I'm having a bad time here. Must be jet lag. We won't tell them that I've been here for a week, right? So, okay, it is hard to see people. So I want people, if they've got questions, to raise their hand. These can be questions of clarification. We've got two people who are going to carry around a roving mic, and we can do questions of either clarification or others for the panel. And I'm glad to see that there's already a question in the audience, so we'll go to the question in the audience first. Over here.
Thank you very much. I'm Emily Banks. I'm an epidemiologist from the Australian National University and the Sachs Institute. I just want to thank all the speakers. That was absolutely fascinating, and I find that there is a sort of mystique around systems thinking, and it was really great to see some practical applications. I was intrigued by your comment about the system goals. You said something about the system goals. Now, I was just wondering if you'd expand on that, because when I look at these systems, it would seem to be that there are often multiple players, each one with different goals, and the idea that the system as a whole has a goal suggests some sort of agency, and I'm just wondering what you mean by that.
So that's a great question. I'll turn to Danelle Meadows, who's really the source of this idea. She says that, first of all, the system has goals, and you may not always understand what the system's goals are, but trying to figure out what the system's goals are can be very helpful. And it's not necessarily your goals for the system, it's how the system operates and where it's headed. So, that is driven in part by the dominant paradigm. So let's take tobacco control as a quick example. 40 years ago, the system's goals were to promote consumption. Smokers were cool, and many of the things that we in public health tried to do were to try to interfere with that particular system goal. I'd say fast forward to today, that's probably changed. The paradigm's changed. Smokers are no longer cool, and people are no longer encouraged to smoke. In fact, they're mostly discouraged. And the goal of the system and all the pieces that we've put together are probably to counteract that or to prevent tobacco consumption. But I wonder if any of the panelists have a different kind of answer or another answer to the question about system goals. Paul?
Thanks for the question, Emily. I guess when I was thinking through and listening to Diane's view about what her view of systems, the goal that I thought about was actually the thing that was absolutely crucial to our planning at the beginning for the Healthy Weight Initiative, was to try and work out what the goal of the ACT government was. And the goal of the ACT government was governing, spending the budget as allocated in their silos. And so the first thing we had to do was to get people to the table to say, well, here's a different goal that you might want to actually join us on this journey. And the first reaction to that was, obesity is a health problem, health has to fix it. And so when we started to look in a systems approach to that and to try to convince people and bring them along with us, the key component there became that co-production for co-benefit. So where we've had our most success was changing the role from we're the sustainability people, we work on sustainability, you do health, to say, well, if we could get active travel working, there's a sustainability goal for you that's ticking that box. It'll get us actively travelling, that'll tick that box for obesity. And if we do it around schools, the example I showed in the talk, then that helps us with a whole bunch of educational outcomes. And so suddenly we had 3 departments that had never thought in this way before, never collaborated in that way before, collaborating in a different way. So we upset the system completely. We then, and the diagram which you wanted to criticise more until I explained it to you earlier, explaining that to a whole bunch of non-systems thinking people in government, particularly in Treasury, is impossible. So we had to re-silo-wise the government in a different way. So instead of being the health department, the education department, the planning department, we had this group which was called urban planning, and that was the thing that really drove that change of the system. We upset the system, and there's been some unintended consequences of that, some positive, some negative.
So I think part of what you're hearing here is that when you're trying to understand the system you want to intervene in, you start by trying to understand how the system's goals are creating the system that's present. And as you start to think about intervening, you think about where you want to send those goals and what you're trying to achieve. Sharon?
Yeah, I suppose that I would add a little bit in terms of, so some of the bad health outcomes are emergent properties out of these complex systems, and being able to the attractiveness to me of looking at the system is being able to see exactly where agency is coming from and can be amplified within that. So the demonstration of not just kind of the causal factors, but the different actors in a system. And if you say, thinking particularly from inequities in health, that you can see, by mapping all of that out, you can see where, on one hand, it looks as if where the power is lying in the system, so in terms of where more agency might be. But you can also see how some of the other parts of the system are all intricately connected, which then really can release agency and power in this part of the system. And so it gives you, I think, a lovely, even if nothing else, just a visualization of the way you can rebalance power and therefore release agency within that sort of system.
Yeah. Okay, another question. Where have we got, where am I? Back there, yep, with the microphone.
Hi. My name's Karen. I work in Brisbane in social policy, and I'm also a PhD student. I saw a diagram recently that was talking about the success of Uber, and they had a positive feedback loop saying that, the more people that are using Uber, the more drivers there are, then the better quality of service there is, and therefore more people will start using it. And so there's this positive feedback loop going, which is leading to the success of Uber. And I was just curious, when you were talking about your positive feedback loops in these complex sort of systems thinking, what you saw as the positive feedback loops in chronic disease prevention, or what sort of things do you think that we could try and get going so that we have this positive, almost self-sustaining loop going on, to help us all in our public health efforts?
Panel, do you have any positive feedback loops that you want to talk about in any of the models that you're, or communities that you're working with?
Well, we're actually in the beginning of that, so I can't quite, coming at me, getting flanked by microphones. So Sharon, I think you've probably got real solid examples of that. I think probably one of the interesting things in the group model building, which was only last week in WA, where we had a whole range of stakeholders who spent 6 hours building a model together of a causal loop diagram of the kind of key issue of engaging with broader people and organisations in prevention within their local community. But one of the interesting things, and I should say in terms of paying appropriate deference, that the group, it's the Global Obesity Centre at Deakin University, who we commissioned to undertake that work with us, and they've got wonderful software. If anyone's interested, you should have a look at their website. But one of the really interesting things that they commented on afterwards was that as a group of people who have been in this process of systems thinking with Prevention Tracker, they immediately, as they started identifying the key variables within the community and looking at the connections between them to understand why things are the way they are in relationship to engagement across traditional silos and boundaries of prevention, they very quickly moved straight into the identification of feedback loops and immediately started looking for those connections in an understanding that those feedback loops actually created the stability in the system that they wanted to effect some change in, and immediately started identifying, well, where would the balancing loops be? How could we redirect these feedback processes to begin to change and alter some of that structure for their own end? I don't have examples because they would need to be front of mind for me right now, but one of the things I was really taken aback by, that many concepts in systems science like feedback loops and reinforcing loops and balancing loops, we as academics kind of need to go away and study overnight and come back with an example. And here we had practitioners involved in local government, health services and hospitals who just immediately got a highlight pen and saying, well, there's one, which makes perfect sense, and this is where we would need to intervene in order to recalibrate that.
Andrew, you've got an answer?
Thank you. That's stimulated some interesting thoughts to me, thinking about Uber and the context of it. The first thought that crossed my mind was Uber's currently, as I understand it, losing $250 million at least a year. And it will continue to do that, and it's as part of its plan, because it's intent on changing a paradigm which will guarantee it an extraordinary profit in the former term. So I think there's another really interesting principle that using that example should make us think about as well. I was also sort of thinking, because you mentioned you're from Queensland, so we'll share a story. So I had a senior position in the Queensland Health Department towards the end of the last Labor government, not the current one, and where the government was throwing hundreds of millions of dollars, billions of dollars in fact, into health because it was bleeding politically in relation to that. And I remember distinctly a sense that government thought it had failed because it wasn't getting a feedback that it wanted, which was an electoral positivity, etc., the problem solved, etc. And it was never going to be solved in that sort of sense. And I think, looking back on it, I think we did fail to communicate and get out what it was that was being achieved through that investment. So I think the point you're making is really well, it has got some interesting perspectives from both sides. So how do we do it differently? And I think this is really important because I think we haven't done a good story, we haven't done a way of selling the prevention story in a way that is believable to people, to communities and to governments in a way that they feel like it's worthwhile continuing to do in a way that goes beyond pointing the finger at people and say stop eating so much and get out and walk. And I think we do need to think through what are those measures, and we have another series of work within the prevention system which is within the Prevention Centre, which is actually starting to try and think about those issues. Not starting, it's a piece of work we're doing, trying to look at different ways of measuring prevention, for example, looking at the issues of productivity gains and how do we measure that as one sort of type of feedback, but equally in how we convey the message and the comparability of what we're doing in prevention with other things, like, for example, the sorts of gains that you can have through prevention, and how does that equate to other forms of things that the health systems invest in, like surgery or medicines, as the case may be, and to sort of start to get people to realise that the sorts of effects that we're talking about are the same sorts of magnitude in terms of what's gained. and addressing the issue that prevention's always sort of as something that's going to happen in 10 years' time, i.e. well outside of their political cycle. And how do we actually make people understand, in fact, that you get gains from these things sometimes very early in the piece?
One of the generic feedback loops that I often talk about as a suggested place to create a positive feedback loop is the relationship between cooperation and competition. Okay, they don't sound like they're the same thing, but let's think about two levels in a system: sports teams and sports leagues, okay? In the league, the most competitive team, which is at the level below it, is the one with the most cooperative players. So if you create competition, you can engender cooperation. And in British Columbia, in the run-up to the 2010 Olympics, the government created a competition for additional resources for ministries that were not health in order to do a health project or a healthy weights type of project. So they created a source of funds, and different ministries competed for these extra funds, but they couldn't be led by the Ministry of Health. They could work with the Ministry of Health, but they couldn't do it. And I think there were some 30-odd projects that were funded in this short-term 3-year period of time that actually the evaluation of them suggested they were innovative, they were helpful, but as is classic, then the Olympics happened and that, government moved on to another agenda, so the fund went away. So we do have to find ways to sustain these things, but there's a way to take a generic relationship, positive feedback relationship between cooperation and competition, and apply it in the creation of new and innovative stuff. Is there anything else that, Paul, do you want to add?
Just quickly on feedback loops. So I think success breeds success, and everyone loves success stories. I came across a quote once where it goes something like this: that the universe is made of stories, not atoms. And so whilst a lot of quantitative, and my background is as an epidemiologist, so I love quantitative data, and putting that to Treasury on an economic basis through productivity and so forth is really crucial. But it's actually gathering those personal stories, and I think this is where Therese's work is really beneficial, because she's right down there in the weeds as it is, listening and hearing and gathering those stories. They're the ones that really drive politicians, and we heard that some of those from Minister Hunt this morning. The things that he mentioned, it was apparently only the good-looking cystic fibrosis kids are getting that drug, not the ugly ones. So I don't know how that works, but you need those personal stories as well as the quantitative data to drive success. And once you've got those, there's a momentum that builds.
Yeah, that's great.
I assure you that that's not the case.
That's another hat that
the pharmaceutical benefit scheme does not fund on the basis of beauty.
Of looks.
Okay. Our next person with the microphone's down here, and then we have a hand raised over there, and I should be looking towards the back, so I apologise, but down here.
Kia ora tātou, Heather Kane from Auckland University of Technology. I grew up with a background in social justice activism, and I've been learning more and more about systems change approaches, but it seems awfully like structural analysis, and it seems awfully like Indigenous holistic worldviews, and it seems awfully like lots of the work that we've been doing with whānau water impact assessment. So I wondered how you thought that it fitted or didn't fit with any of those three traditions.
Well, I won't speak about those three specific traditions, but just make the comment that one of the challenges that I think we face in public health is this isn't something new. There are many, many different disciplines that have given rise to what are essentially very similar or the same systems approaches with different language. So part of the problem is that we don't have a common language and logic yet that we can all turn to, or theory of complex adaptive systems as applied to public health. And so we all pick and choose the ones that we actually find the most, I guess, intuitive for ourselves or whatever. So I think there is you articulate, the subtext of your question is really quite a problem, I think, for public health, that there are these many, many different disciplines. But others, do you have comments or something to add? Sharon?
Yeah, so I think it corresponds to each of those, I think completely, and I don't think it matters really how you think, how you articulate that. I mean, if you think of how different fields progress over time, you draw on pieces from different places, and that's fantastic. I don't think we need to be worried whether it's a structural analysis or whether we call it a particular type of systems analysis. I think what was lovely, Diane, actually was that just that demonstration of different approaches that we can do this, and some of them will be relevant for some questions and some of them will be relevant for others. I think it's exciting within public health that we're thinking in this way. Others have been thinking in this way forever, and they look at you as if, really, are you this late to the party? But that's okay. That's the evolution of the field. I don't get worried at all with the fact that we're using different.
I'm going to challenge you a little bit on that, because I really think that we've been at this for more than 10 years now. I mean, that systems map for obesity came out more than 10 years ago. And TAPS has done a nice study talking to decision makers and asking about systems approaches, and it suggests that everybody thinks, this sounds good, but where's the evidence? How are we going to advance the field? And I would contend or hypothesize that part of the reason why we're not moving forward faster with systems approaches is because everybody's got a different way of talking about it, and it's not pushing us forward faster. Think about how evidence-based medicine and its pyramid, it's, 20 years old or 25 years old, whatever it is. It's not that old, and yet it's taken over in a sense, and is actually a bit of a problem, if you ask me, because I think we need to turn it on its head. So I would beg to differ that I think having a bit more of a common language and logic would help us move faster. Am I wrong? Andrew, you were sort of shaking your head there?
No, not at all. The first thing I wanted to say that is, if we can trace the origins of our systems thinking to the three areas that you talked about, then I'd be quite proud to be associated with them. I think those have all got attributes that we would want to welcome into it. The second thing is that for 10 years, I had the privilege of working with a group of communities and researchers in North Queensland on a thing called the Family Wellbeing Program, which was an empowerment program for Indigenous communities. And I learnt lots of things from that, an enormous number of things from it. But one of them was about the sense of the importance of whole, the importance of thinking about the whole, and with the W, and that holistic nature of health, the holistic nature of life. And as soon as you start to do that, the grasp of complexity that exists in that thinking is enormous. I mean, it's fundamental to what it is, but it's not something that's easily conveyed to the sort of hard-nosed people that we have to work with, the decision makers in Canberra, in state governments, and wherever. Whereas system thinking has a framework, it has a methods that they can relate to in some way or another. So I think it has a purpose, and we've been able to demonstrate that on a couple of things that we've done so far. That the comfort of that they can engage with it, they can see what's actually happening when we use some of this agent-based modelling and things like that to give them a sense of what's going. So I think it is a very, very useful, and I think I said that in my introduction. The thing for me is that it's provided me with a framework which is sharing the background with Paul in epidemiology. We look for these sort of rational and numeric answers to things, but we know in our heart that that's not the full story. This at least starts to enable us to give us an approach where we can get a fuller sense of a way of looking at the full story.
But we need more empirical evidence that a systems approach actually gets us further faster in prevention, and without a more common, logic or language and logic for it that we all adhere to. I'm worried that we're still going to be spinning our wheels for a long time. Maybe there'll be good positive feedback loops, but maybe not. So I don't know. Any challenge or Sharon? Since I challenged you.
I am conscious there's still a few hands because
okay.
we'll come back to it.
Okay. All right. So where's our next? I think our next one was here in the middle, correct?
Is that okay?
Sure is.
Monica Bensberg, Victorian State Government, Department of Health and Human Services. Thank you. Conference highlight, everyone up the front, so thank you very much. One comment, the obesity map's famous, but if people took the time to read the reports that accompany the obesity maps, they're the best how-to for systems approach in health promotion I've read, and I'm doing a PhD in systems thinking at the moment, so they're very accessible. And so the Foresight reports, they're 10 years old, but they're just awesome. And there's a little one called Building the Obesity Map that talks about not the 108 variables, but the 24 around food and the 28 around physical activity. And it describes the intervention points with the best sort of strength behind them. So if people have got time, I'd really encourage them to, they're like your beginner's guide to systems thinking for prevention. So I found them really useful. Building on, this is my question, is this stuff too sophisticated for community-based practitioners to do on their own? Because the stuff I see is when the unis come in and when the consultants come in and they need help drawing the causal loop diagrams and they need help doing the group model building, and there's this level of sophistication that seems greater than other prevention theories. Is it too hard for practitioners at all levels?
I wonder, Therese, I'm thinking about you and with that question, but Paul, you also wanted to say something.
We can talk about policy makers practitioners. No, it's not too sophisticated. Certainly I think time will tell with Prevention Tracker, but to date I haven't been challenged more on my interpretation of data. Had people creating links and patterns across data that a team of people who assumed we were rather bright couldn't identify as quickly or as in such a sophisticated manner. That said, one of the things we're very conscious about in Prevention Tracker is that what we want to be able to do is place into the hands of practitioners the kinds of tools that they could use to be able to monitor system change efforts, and that is a key part of Prevention Tracker, which is why the kind of software that the people at Deakin University have created, the STIC-E software in the creation of causal loop diagrams, is designed explicitly to enable community members and practitioners to be able to create those kinds of causal loop diagrams. So in the work that we're doing, working with the communities to build that model, and then the model is in the hands of those community members to begin to identify where those changes in the system can take place, and to be able to say, and look, we've actually created new balancing loops, and that's brought about the kind of system level change. I was gobsmacked at how quickly community members and practitioners just immediately jumped on feedback loops and vicious and virtuous cycles, like this is just a part of day-to-day practice. And then how could we possibly create new balancing loops, as I said before? They were immediately focused on the structural aspects of the system that they saw as critically important in terms of being able to affect change, so that whatever the prevention health priorities may be for that community, whether that's smoking or physical activity or nutrition, that system is going to be better placed to be able to deliver those kind of prevention efforts in the most effective manner. So, geez, that tips my lid, honestly, in terms of the skill and knowledge and expertise at the front line. And I think the main thing for us, certainly at TAPS and within Prevention Tracker, is how do we surface that and enable more of it so that we can learn from what practitioners just do on a day-to-day basis.
Paul, did you want to comment?
Yeah, a couple of things. So it's not everyone's cup of tea. Some people get completely confused, and so I'd often make the joke about why our immunisation rates are so high in Canberra is because we're all public servants and we just do what we're told. So some people are much more comfortable in that. They don't want to see the system. They just want to be told to do something. They want to know that that's what they've been told to do, and they'll do it. And we've had that experience. But on the other side, we've used these things with high school kids, and some of the work we did with Deakin and some of that informed the STIC-E process that Therese is mentioning. They just get it immediately. They can think through these things in much more complexity than we ever imagined, and that has led to really interesting outcomes, very, very much embedded in People can see themselves in these diagrams. They can see their world, they can see these feedback loops just implicitly. The ones, and this is another session which is on Wednesday, I think, but encourage you to come to. But working with clinicians, who I would have thought would have been totally involved with this paradigm of evidence-based medicine, randomised controlled trials, one intervention leading to an outcome, epidemiological sense. They've got it. And so one of the things we've done around diabetes and involving clinicians, policymakers and others, community groups as well in the room, this has been a great way of breaking down those barriers and everyone seeing themselves in a complex system around gestational diabetes, this particular one. But there's been other work in dynamic system modelling exercises that TAPS has been involved with in alcohol and others, and I think there's some presentations on that as well in the conference. So it's a tool. These things are tools to allow us to come together to recognise issues and where to find these interventions and some agreement across what were previously insurmountable boundaries. That's what I've experienced.
Yeah. What I was going to say is that I think just like there's a range of people who find this intuitively easy to understand versus don't really want to go there, there's a range of tools out there. Some are quite intuitive and easy to understand, and that's part of the reason I wanted to focus on frameworks, because many of the frameworks that were presented, most anybody can pick up and utilize for a conversation or an approach. I think, yes, there are also methods that require more sophistication. Sticky's a nice bridge to being able to do causal loop diagrams without a lot of sophistication, but then if you want to do a system dynamics model, you probably need more capacity than the average individual practitioner is going to have. And so I've tended to focus on the stuff that was relatively easy, that's intuitive, but there's a range, and it all depends on what you're trying to accomplish as to what's the best way to go about it. So I think that's the other thing to keep in mind. Now, where's the next microphone? Is back there.
Hi, my name's Bev Lloyd. I'm at the New South Wales Ministry of Health. My most recent job, I've left it recently, was involved in managing the implementation and evaluation of the New South Wales Get Healthy at Work initiative. And one of our aims of Get Healthy at Work initiative was to, in short, make workplace environments more health promoting to reduce chronic disease risk. What I've found in managing the program is that essentially businesses have their own patterns of behaviour over time, and they would not be compliant with my beautifully designed linear program. However, my boss, the New South Wales Government, the Chief Health Officer and the Director of the Centre for Population Health, requires significant reach and effectiveness of that type of program. So I guess my question, which I don't expect you to answer now, but I'd certainly like to talk about it with some of you later, is how can I use those frameworks and complex systems maps to guide action to take a systems approach, but at the same time meet the objectives of my boss?
I'm going to turn to Paul to see if he's got a comment.
I was just quickly going to my 19 actions in the in the Healthy Weight Initiative, which several are similar to yours, as you know, Beth. But look, I think it's quite interesting. It comes back to I'm not sure if she's still here, but the person that mentioned, well, isn't that just the stuff we used to do before? I mean,
Just move back 4 rows, that's all.
all right. From the Maori models and so forth of holistically looking at health. But I guess the issue for me is that in workplaces it's really hard to get past Pilates and Pilates back rubs at lunchtime is another good one, and fruit bowls. So they're the 3 things when we go to engage with workplaces, that's what people go to and that's what they know. And of course, what we're wanting them to do is in a health promoting workplace is actually look at the fundamental determinants of why people are unhealthy. Sitting all day at a computer, long hours, stress, all of those things that are leading to the ill health. And these are window dressing in a way. So trying to get those holistic views in there is really, really difficult. And it comes back to my other point about what can government do in those things. Well, you can provide incentives, you can provide, you can regulate, you can lead by example. But again, in those circumstances, I don't know how you find working within New South Wales Health in terms of actually trying to, or hospitals to try to make them health promoting workplaces. But it's damn near impossible in the ACT, I must say. That's been the most hard nut to crack. Yeah, but it's important. You know, that's where we are all spending a significant part of our lives, and so we can do a whole bunch of stuff in school-based settings. We can kind of be nannies there in a way, but to try to push too hard on those workplaces without that kind of fundamental reform of what work is and how it's performed, I think it's really difficult. So good luck.
Andrew, do you have some sage wisdom here?
I mean, I think there's also the first steps, the conceptualisation of what you were talking about, the co-design component, which I think is something that what we're trying to bring to the table, that if you had actually taken that approach from the start and started to think through those issues and think through the different stakeholders and their different interests and all the different interacting factors that came into it, then you would have probably had a different set of measures from the start. You might have had a different set of interventions. It may well have been that you still had your back rubs and fruit bowls as part of the entry, but I think you would have had a better, you would have conceptualised the complexity of what you were trying to achieve differently, and you might have some different metrics about how you measured success in that environment.
Sorry, Diane, just
go ahead.
one thing we found very useful in our pilot programs in relation to this was actually bringing in the insurance component. So it became a industry actually promoting this. So I'm talking about workers' compensation in Australia at least. You can decrease your premiums if you've got a healthier workplace, and so that actually starts to encourage some of the businesses to actually really go down further on that path. Okay, we can really actually save money here as well as be good to our workforce and get better productivity and have a health gain. But for them, the health gain wasn't the important thing, it was these other things. Co-benefit again.
Okay. Now, I thought I saw a microphone down. Okay, way back there. And we've got somebody down here who's been waiting for quite a long time for a microphone. So, at the back. Thank you. Jackie.
Hi, thanks. I'm Alan Murphy from the Alcohol and Drug Foundation, and we're responsible for delivering the local drug action teams project that Minister Hunt announced this morning. So thank you for your conversation. I think it's been really useful for us as we're looking to embark on a prevention program across the country. I guess I'm interested in your insights around how we consider a systems approach with knowing that in the local context often the push is to go down to acute or harm reduction approaches, and we're pushing people just to get them thinking about prevention in its purest sense from alcohol and other drug use. How actually we can consider that systematic approach or help people work toward that at the same time as just moving into prevention itself, and I guess take the best opportunity that we have at the moment.
Andrew, I mean, I think your co-production, what you just said is highly relevant here.
The other thing I'd point to is you pointed out one of the earlier questions was talking about the foresight report, and the thing we always see is that complex system diagram, and as was pointed out, there is actually a lot of other really useful information in that. There was a lot of quite careful thinking about it. And one of the bits actually is the complex diagram's nice when you want to illustrate talks. But the bit of the report that I really like is that, and it goes back to one of the principles that I believe that I think that one of my sort of working principles is it doesn't matter what colour the government is, there's always things that you can do with them. And the trick that we have to get better at is identifying the things that we can do while recognising and continuing to follow through on what we really understand the system to be like. And that foresight report, one of the nice bits of the foresight report is it looks at sort of political dimension. It says, if government's sort of crudely blue to red, what are the sorts of things that you can do along the continuum of action, depending on where the government of the day sits in relation to those actions. And it then lists all the interventions that they identified at the time along that spectrum, and it sort of gives you a sense of the things that you're likely to be able to win at different times. It's not that you shouldn't stop trying to do the more profound changes, but you've also got to be realistic about what you can do at a particular point in time. We've done quite a bit of, we've done some modelling work in the alcohol area, and if you haven't seen it, you're more than welcome to there's a link on our website to the modelling work we've done in that area where we've tried to understand the interaction of some of these things, and some of the results that modelling has produced have been very interesting in terms of the counterintuitive outcomes when you start to take into account some of the feedback loops and things like that.
I mean, when you asked the question, I was thinking about the answer you gave earlier about co-production of knowledge and how important that is, particularly in things like alcohol and tobacco in particular communities now, because one of the stories I'll relate, I was at a tobacco control meeting recently, and I learned that in some communities, in some Indigenous communities in Canada, tobacco is a form of harm reduction from alcohol. So you need to understand those things in order to work within a system in a particular population. So I think that those are the kind of things you'll learn if you're working and engaged with the community that you're trying to address this with. But is there anybody else on the panel that has an answer? Sharon?
Just to mention the sort of the common, if you remember, the common risk factor approach, but the opportunities, if you're thinking from I don't know so much from a drugs prevention, but certainly in terms of alcohol as a drug, you've got common alliances there. I mean, one of the big drivers around alcohol consumption, junk food consumption, is the retail environment. So if you're thinking about prevention, so the issues of availability, accessibility, affordability, we speak about them in the food world, you speak about them in the alcohol world, and it was the same within tobacco, of course, as well. So you've got common alliances that I think if you think about land use planning, the sorts of regulatory environment around the retail outlets, I would recommend, and that's you're starting to talk about that wider system. Then I just think you've got some real opportunities. Certainly in Australia, if I remember correctly, that the forecourts, the sort of the petrol stations, forecourt shops, which is where so much junk food gets purchased. It's readily available, it's been purchased, but that's also where alcohol is now most commonly, if I'm remembering correctly, most commonly purchased. So thinking about the forecourts and the petrol stations as a place to intervene from a prevention perspective, you've got some multiple co-benefits happening there.
So I think we have time for one more question, and the microphone is here. I'm sorry, unless we can get a microphone down here and keep it quick, because this poor gentleman's had his hand up for quite a long time. So,
Peter.
Over there.
Thank you very much. I'll be patient. Thank you very much for all your presentations and the following discussion. It's been absolutely fascinating. I've been a student of systems thinking for over 10 years since an Indian student introduced it to me, and I had to supervise him for his thesis. And it's fascinating to see how it's come along, and I'm thinking of applying that sort of system to my research into health service management competency and performance, and I look forward to trying to do that. I'm just wondering, Therese, you mentioned, it seemed to me that your intervention or the activities you're doing seem to be really the most grassroots of all the examples we've had. And I think that, to me, that shows that it's when you get down to the community level and to talk to individuals and to empower them to do what you want them to, what they should be doing to prevent chronic disease, that's where whatever system you use, once you've empowered them to recognise the problems, and then they can start doing something about it in their own way. And I think that's the secret, which systems may open up to us, because, and that's not new, that's been going on for decades and decades in global health, in local health. So I just wanted to say thank you for your description.
Thank you for the comment. And I think we'll go right down to the front here with the last question.
Thank you for a brilliantly stimulating session. Here are a couple of thoughts that you stimulated. On Diane's comment about if we're going to have empirical evidence and take this forward, we will surely have to integrate some of these things in. So a mapping of all those different approaches into one where we have consensus as a group of researchers, that way we'll build the empirical evidence. When it came to what are the goals, what really are the goals, it struck me that in the workplace setting that we were discussing a minute ago, the real goal might be about reducing absenteeism and increasing productivity. And until we map our goals across those and engage that bit of the system, we're not going to be successful in workplace settings. My last one is about the feedback loops. Which are the positive ones and which are the negative ones? And I was thinking of Healthy Together Victoria, slightly odd example where the Greatest Loser came to town. People got really engaged, but they got real-time data, really quick feedback, not a year later. And that seemed to be really empowering and energizing. If I was to think of the negative feedback, it's the one that comes from industry all the time through their use of big data and marketing through mobile apps and in everything else. And we don't do enough to take that feedback loop out of the equation.
Mm-hmm.
Thanks for a great session.
Yeah, great comment. And I'm going to close it there and go away with this huge list of questions I had that I didn't need to use any of because you guys had such fabulous questions. Thank you.
Thank you, Diane. Let me just quickly then close. I'm not going to try and summarise all the many things that we've heard today, and I couldn't do justice to them all anyway. But I would just like to draw your attention to a couple of things in closing. As I opened with, I think chronic disease is one of our greatest health challenges. It's a complicated problem with many entangled factors. We've discussed many of them today. There's not going to be a simple solution. If it's a complex problem, there will not be a simple solution. But I think we have to be careful not to see complexity as a real reason for nihilism. And there is a sort of sense around some of the issues that we deal with, alcohol, obesity, a sense of that we can't get any traction. But in fact, we are. And what we think is, and in the Prevention Centre, we think there's a set of tools that can help us get there a little bit faster in thinking about those things. We don't think it's a panacea, and it's got its place. The question before that we had around, well, so what's this for practitioners? Well, one of the things is that practitioners, if they find something useful, they take it on board and they use it. And I don't think we should underestimate their capacity to take on tools like this. And I see our role as trying to pull out the elements and help them understand it and learn those things. So if they are useful in their practice, it's available and they can do it. Just to let you know that if you are interested on our website, we have a fantastic collection of resources. There's a couple there that we've developed ourselves, but there are many other ones that we've been able to source from different places and have made accessible there with easy links, etc. Everything from self-learn books that you can download, which are free, and that work you through sort of examples and problems, etc., to some of the more advanced texts, some of the resource materials. They're there if you want to do it. So just in closing, let me just say thank you very much for the rest of the panel who've given their time and, more importantly, have given their energy and their intellect to the Prevention Centre and our adventure. We hope that some of you may also want to join us and will contact us and come along on our trip, which has been really exciting for the 4 years we've been going so far. So thank you all very much.